Hey guys, Jordan Bird here. This is the week 3 blog skills post. I'll get right into it. From the skills questionnaire, I think there are a couple of really important points, really important skills to be able to implement to be an effective manager. I think the first one is effective problem solving skills. I have to say, staffing is probably the biggest problem we have right now on the neuro ICU unit. It's not uncommon to have only 3 or 4 core staff on a given shift, especially night shift. So you're kind of left with the bulk of your staff being travelers, float pool nurses you might not be as familiar with, new grads even, step down nurses. Sometimes it's difficult to find staff and to make assignments from a charge nurse perspective if you're not really comfortable and not too sure the strengths and weaknesses of your staff, who can manage EVD equipment like that we see very commonly in our stroke patients, hemorrhagic stroke patients at Duke. And of course, there's always call outs, being able to communicate with the OA, the staffing office, other charge nurses who may have available staff that can float to you, preferably from the ICU. So it's just a kind of a constant line of communication there to uh, effectively problem solve the nursing shortage, if you will. The other one is using emotional energy to motivate others. I'm not really a emotional rah-rah kind of leader. However, I feel like being a presence as even a neighbor or in the charge nurse role to help out newer nurses especially. I think something as simple as just giving them a turn, um, checking a blood sugar, starting an IV, doing some simple tasks can really take some pressure off of a new graduate and let them do a better job with their patient care. I'm just a big believer in teamwork and everybody working together towards a common goal. I also think this can help retain staff as well to try to build a more solid foundation to help out the other problem of having a nursing shortage. Let's see, from the textbook, I have to say the one that stood out to me was directing. Um, the textbook broke it down into 5 kind of subspecialties of directing. It was let's see, giving direction, supervising, leading, motivating, and communicating. Out of those 5 areas, I probably feel like supervising and communicating are probably the top 2 that I would implement. Let's see, Dr. Jennings in the textbook identifies traits of successful supervisors, some of which, but are not limited to, one who gives clear orders and communicates well, praises others when deserved. I feel like as nurses are developing their practice, I believe it's helpful when they hear that they're doing something well, not just all the stuff they need to improve on or that they're not doing as well. I feel like it's some positive reinforcement is helpful for younger people. Um, a leader who has self-confidence. I feel like people are more apt to follow leaders that display confidence. It makes them believe that if the leader is this confident in what he or she is doing, they're probably more apt to kind of fall in line and go with what the leader's showing them or telling them. Um, and the last one is, let's see, good leaders demand good work from everyone. I feel like a role of a supervisor or a manager is to um, give his or her workers the resources and the opportunity to be successful. And in return, I think that it's fair for the leader to expect a certain level of accountability and a certain level of performance from the staff, given that opportunity and resources and knowledge. See, the article I chose is titled Jefferson Interprofessional Clinical Rounding Project, an Innovative Approach to Patient Care. This article explores if interprofessional rounds could be implemented in an acute care setting. I found that interesting because in my unit we do bedside rounds. Usually the team consists of an attending physician, either a fellow or resident who generally runs the rounds, with the attending kind of being the overseer, a nurse practitioner, a respiratory therapist if the patient is on a ventilator, and the bedside nurse usually as well, along with a pharmacist. So it's kind of a big group there. The results from the study showed the participants were more engaged, felt like they had a higher level of satisfaction, felt more as a member of the team. They felt like they were a member of the team a little better, and also developed a better understanding of the role from each interdisciplinary team. I feel like this is a good way to run rounds and to run a unit even in the ICU where things change and rounds do get interrupted. From a managerial standpoint, I think I'll probably focus more on that with new graduates, especially. A lot of times they come to the unit and they're either totally not prepared or either have no expectations or maybe have the wrong expectations. So I think it would be beneficial for the first week or two of orientation to maybe shadow the rounding team as opposed to individual nurses with their patient assignments, and that way they can hear how each nurse communicates with the team, voices his or her complaints, concerns, kind of works as the middleman between the family member and the team. The family members are encouraged to participate in rounds as well, so it lets the new hires know to make sure the families and patients, if available, if able, will participate in rounds as well and try to get their questions answered in a timely manner. It just makes things go much smoother. I think maybe even scheduling a meeting within the first week or so, get an attending, maybe a nurse practitioner to come in for a few minutes and just introduce themselves and kind of what the new nurses can expect from them and their co-workers in rounds as well. Let's see. As far as the levels and departments go, I think as a unit manager or a frontline manager, even something like a charge nurse, I think the most important level to work with and to listen to are the bedside nurses. I think meetings with middle management, top level management, I think they're necessary, and they have their benefits, such as discussing staffing issues, going over the organizational structure, values, new goals for the hospital. I know at Duke we're building a whole new med-surg step down wing, so kind of get on board with everything new that's happening at Duke. I think that's pretty important, but I think without a good, solid nursing staff, all this really doesn't mean a whole lot. We're the nurses are the ones that are taking care of these patients on a daily basis, and we have the most intimate contact. We probably are in the best position to influence their outcome over probably any other discipline at the hospital. I would also utilize managers on other units. I feel like if a certain unit, especially a closer sister unit like another ICU, is having better luck with their staff retention, let's say, I think it's not a bad idea to try to learn some methods in how the nurse manager is keeping their staff. I think it's very important to keep a good core staff in any unit. I believe people working together, working well together, creates a better team, creates better patient outcomes. I think as far as a horizontal or vertical structure, I would prefer a horizontal structure. Maybe that's just because that's what I'm used to working in at Duke. We have many different departments and disciplines, staff with doctors, nurses, techs, etc., who are very efficient, very knowledgeable in their certain area of expertise. I think it works very well to have departments like that. I prefer the team nursing model. Um, this model consists of a senior professional nurse, according to the textbook, or in most cases, probably a charge nurse. Other RNs, LPNs, which aren't as common anymore, NAs. Um, we use this particular model on my unit as well. We have anywhere from 20 to 22 beds open, just depending on staffing needs. There's usually a charge nurse for the entire unit, coordinates bed flow with the triage attending or the resident who might be holding the triage pager. Delegates tasks to the NAs. Usually, as charge, we're kind of the overseer of the NAs as well. We kind of delegate really ADLs, eating, bathing, stuff like that, vital signs, um, point of care, blood glucose checks, things like that. And also, obviously, makes assignments for the next shift. I believe probably the most important part of a charge nurse's duties is probably acting as a resource nurse. We don't have a patient assignment, so I think it's good for us to go around and, like I mentioned earlier, make sure everybody is caught up. If anybody's falling behind, see what we can do to help get them caught up, so the patient doesn't suffer as well from a nurse that's kind of in over his or her head. Travel to MRI, necessary things like that. So that's pretty much it. I feel like communication is a really big, important part. Problem solving. We don't always have resources available at our fingertips, so kind of making do with what we have, I think, is a big deal. And just from a managerial standpoint, just making sure everybody is on task and has proper direction and everybody's working well together as a team. All right, have a good night, guys.